Hello, here we go with Competency 6. We're pretty much done with uh, Module 2, Module 3, and Module 4. I plan on opening both of those up sometime before the end of the week. So stay tuned for that. Also, there's a survey, a midterm survey, so you're going to want to please complete that. I will send out a reminder with a link, so please click on that. I've read through some of the suggestions, and I agree completely with those suggestions, and I will do what I can. I have most of the suggestions involved more test prep, um, more of an idea what's going to be on the test. So what I have added review areas under the units. So you're going to want to check those out. Those review areas in the units are going to have, they're going to open up a Google Doc that's going to have the questions or similar questions that you might see. I will try to kind of emphasize certain things in this video with the immune system for exam 6. But really the main thing you're going to want to do is start with the engage portion, go through the Padlets. There's our key terms. There's a key terms link under the engage folder. Then you're going to want to go through the comprehend, work on the case studies, look at there should be a link for Quizlets in the practice folder as well, so that there are tons of questions very similar to what we would see or what you would see on the exams. The PhysioXs will also help you when you're doing the exams. And then finally, under the apply folder, you're going to find links to those documents in Google Docs that will have examples of the types of questions you'll see. So anyhow, you also are going to want to look at the slide. Watch the slide videos, view the slides separately as well. You're going to find the notes section contains a lot of valuable information that you'll see on the exams as well. So anyhow, we'll keep going with that. I may try to tweak it a little bit, the documents that have those exam questions, but I think for now, please go through those, go through the PowerPoints. I have noticed, I started putting those in for exam 4, exam 5, and exam 6, and I have noticed the scores have gotten increasingly better from the first couple of exams. So anyhow, what was the other thing? As I open up module 3 and then module 4, my goal is to have these videos and PowerPoints all ready to go. I know some of these, I've been doing them during the weeks of the units. A lot of you do work ahead. So one of the suggestions was that I put these PowerPoints and these videos in as I release the modules, or as I open up the modules. So anyway, so it would give you, so as you're doing Padlets, case studies, PhysioXs and exams, you would have the PowerPoints and the videos as well, which you do if you're going at the pace, that week to week pace. But again, I know several of you do like to work ahead, so I'll try to get that get those videos, these videos, the lectures out there sooner than later. So anyway, the immune system. Competency 6 in the patent book, I think most of you still have chapters 32 and 33 is where the emphasis is going to be. Now, I would say 70% is probably going to be from chapter 33 and 30% from chapter 32. So 33 has a little more bulk to it is what I'm trying to say. And then if you're using the OpenStax text, chapter 21 is where you're going to be for that. So when we look at the immune system, there are a couple of terms I think that many of you are probably familiar with. The word antigen is the first one we see. We know that the immune system has to be able to communicate with foreign cells, with self cells. So antigens are the mechanisms that, one of the mechanisms that cells use to communicate with one another. They're unique to the cells that they are contained upon. We find antigens on the surface of cells, so on cell membranes. They're protein based, so they are structural, and they do we do see antibodies connecting with or linking up with antigens as a way of communicating. So sometimes that communication can trigger all kinds of responses, such as an inflammatory response. So we'll talk a little bit more about antigens and antibodies really throughout this immune system competency or module or unit. We see the term self and non-self. Generally, we think of self immunity, the molecules that the antigens that are on the surface of our cells that are normally there. So self antigens are yours. Self antigens are, for the most part, very similar from person to person. So non-self antigens, again, are going to be found on non-self molecules or foreign bodies or foreign molecules, so or foreign cells. Self-tolerance, that's your body's ability to generally only target non-self cells or foreign cells, so and to not attack our own cells. Although we know, I think most, if not all of you have heard of autoimmune diseases or autoimmune disorders. That occurs when our immune system is recognizing self cells as being non-self. So in essence, the immune system is attacking itself. So we also see a couple of categories of immunity, innate immunity and adaptive immunity. We know that innate has to do with being born with. Adaptive means you attain or adapt to the environment around you. Generally, we would say innate immunity is also called non-specific immunity. So these are, again, a lot of physical barriers, physical mechanisms, some chemical mechanisms that we are born with that are a part of who we are. They're not specific to non-self antigens. They're, again, more or less for protection and for providing that first line of defense. So adaptive or specific immunity is going to target specific harmful objects or harmful molecules, harmful particles, whatever that may be. Again, much more specific. So as we go throughout, we're going to be looking at and kind of comparing innate immunity and adaptive immunity. So this first chapter, chapter 33, in essence, goes through some of the basics of innate immunity while introducing you to adaptive immunity, which is chapter 33 in Kevin Patton's text. So anyhow, this is figure 32-1 from the Patton textbook. It shows us a nice little illustration of the differences between innate and adaptive immunity. Again, innate immunity, these are built-in protective mechanisms. We see epithelial barriers. Remember, epithelium, going back to general A&P, epithelial tissue is a lining or a covering. So we would think of the epidermis of the skin as a type of epithelium. We would think of the linings of our cavities as also being epithelial in origin. So all of those, and when we looked at these in general, you'll recall that epithelium function, one of the main functions, is protection. So that we consider that part of the innate immune system. So epithelial barriers. We also see what are called phagocytes. And these are cells that tour around and eat things, or they're kind of like vacuum cleaners. They basically are cleaning up cellular debris from that occurred from apoptosis or some sort of digestive mechanism that occurred within tissues on the cellular level. So phagocytes, these are big eaters that go around and basically keep things clean. And then we see what are called natural killer cells and complement cells. And both of those may be new terms to you. So I'll go through what those mean in this chapter. So, but these are natural, innate immunity, non-specific. Okay. The hours, notice the time after infection. So if we do have a microbe infection, short period of time to get that non-specific innate immunity to respond. So this is kind of, like I say, your prevention mechanism. So these guys are working constantly to maintain homeostasis. Now, we do see for adaptive immunity, we notice from time of infection and getting some sort of antibodies produced, or getting your effector T cells to come in and attach to these the antibodies and antigens. That can take several days for adaptive immunity to really kick in and start working. That's why oftentimes when folks get infected with some sort of a virus, usually the first 2 to 5 days are when we see a lot of the fevers, a lot of the body's response mechanisms regarding inflammation starting to kick in. So anyway, mainly because it's more complex, which is what chapter 33 gets into, is how adaptive immunity works. How do we develop some sort of special mechanism to destroy whatever that foreign invader is? How do we create antibodies to fight the infection? So we have what are called B lymphocytes, B cells. You always want to relate to antibodies. And then T cells, or T lymphocytes, we'll see they don't produce antibodies. They actually have a little bit more of a physical creation and physical helpers that we'll see somewhat relate to a cascading effect and allowing the recruitment, or what we call cloning, activating clone cells to attack the foreign body, the pathogen. So anyway, this is the next chapter. I'm not going to talk about B's and T's anymore for the moment. Our focus is really going to be on some of the, going a little deeper into some of the basics of innate immunity. So Epithelial cells, again, we're going to see epithelial cells on the surface or lining something. So mucous membranes, for instance. Phagocytic cells, again, we're thinking about cells that go around eating. Neutrophils, one of our white blood cells, and macrophages playing a role in kind of keeping things clean throughout the body. These natural killer cells as well. Again, here in a few minutes, I've got a couple slides that we'll talk about NK cells. These are going to basically help keep cancers and uh, hypermitotic cells from getting out of control. So we'll take a peek at those. And then cytokines. Kine, of course, has to do with movement. Cyto means cell. So cytokines are going to trigger some sort of immune response. They're going to trigger movement, basically, of more inflammatory cells. So we typically see cytokines coming in and being and basically triggering this domino effect of recruiting more self cells to come fight the infection. So there are several different kinds of cytokines, interferons, interleukins, leukotrienes. So one of the things right now with COVID-19 is we're seeing what's called a cytokine storm. So the COVID affects, has its own RNA, doesn't even have to necessarily go to the nucleus of a cell to start the process of transcription and then translation to alter the structure and function of some of these, especially these mucus-producing cells in the lungs. So what that infection does is it triggers a cytokine storm. We've got a foreign invader. Your cells recognize it and triggers the storm. And what that oftentimes does is triggers the clone cells that we have that are kind of hanging out, waiting to be told what to do. They're kind of like the reserves. So we've got a whole bunch of reserves that are hanging out, waiting to get the call. And all of these reserves have different specifics regarding what their specializations, I suppose we'd say. So these different specialized cells are kind of hanging out. They're clone cells of other B cell antibodies or B cell lymphocytes. Have specific antibodies. So anyway, we say, oh, we want this group, group number 4, we need you over here. And so the cytokine response may be, or the inflammatory response to an infection may involve cytokines triggering the release of a specific type of immune fighter. So a specialist, if you will. Now that can, depending on the degree of the infection, that cytokine getting triggered could cause a storm of cytokine activity, meaning we're going to get a little bit can lead to a lot bit. So it basically is what is going on. So your own cells start reproduce, your immune cells that are specific to fighting an infection are going to show up on the scene, and then they're going to go into like a hypermitotic, hypercloning phase. And so what we end up with is way too many of our own cells even. That creates this accumulation of mucus. It creates an accumulation of inflammation. We basically, the alarm gets triggered and we don't know how to shut it off. So the dam breaks basically regarding our own immune system. So COVID-19, and a lot of viruses have the ability to do this. COVID-19 and a lot of these other SARS type viruses, they have the ability to really trigger and get the cytokine storm started. And so anyway, that leads to a lot of inflammation, a lot of heaviness, thickness, excess cell debris. So now phagocytes, macrophages, neutrophils, these guys get triggered. They have to come in and vacuum up and clean up all of this mess that's being created. So they almost behave like autoimmune disorders. These viruses, they come in and they wreak havoc. Oftentimes it's not the virus itself that's wreaking the havoc, it's the kind of the after effects of the virus being there, that our body's responding in a hyper responsive manner, in a storm, when maybe we only need a mist or a shower, and instead we get a typhoon. So needless to say, our own immune system's response to a pathogen, it can sometimes be deleterious or have negative effects. And that's what we're seeing with COVID. That's my point. So anyway, it's a lot of rambling, but I think at this time, the immune system obviously is always a big deal, but we're seeing and hearing more and more about some of maybe how it functions, how it operates, particularly with with the COVID-19, that particular virus. So anyway, so these are all of your innate immune cells. You've maybe heard the word histamines, certainly enzymes. All of those play a role in innate immunity or non-specific immunity. All right, so anyway, adaptive immunity, that's the next chapter. Again, we'll talk more about B cells and T cells. So types of barriers that we see throughout the body. So again, that first line of defense, that we'll see these lines of defense here in just a second. But do we have what's called species resistance? So like I said, the non-specific innate immunity from person to person to person is generally going to be very similar. Whereas dogs or elephants or porcupines, whatever, platypus, they're going to have their own structures and innate adapted that they adapted to over long periods of time to establish an innate immunity. Adaptation, not to confuse adaptive immunity, adaptation is a process that a species will in essence evolve to be able to handle the environment that it lives in. So immunity, innate immunity that is you're born with, took some time, potentially several generations maybe, to establish. So if a species is affected by something new, like COVID-19, for instance, we start to develop our own resistance to it, or our own defense against it, or our own way of fighting it if we are infected by it. And then we have children, and they develop that, and then they have children and they develop it, and so on and so on. Well, after many, many generations, the body may start to develop more of an innate or a born-in type of defense mechanism that will help fight against something that is just a part of our environment. So they call that adaptation. So that's a long for for most of us, or for most species, we see this happening over many hundreds, if not thousands of years. So if not millions. So, but anyway, that's what the species resistance, and then mechanical and chemical barriers. Again, we talk about the skin. We see the mucus lining and the mucous membranes. Um, let's see. So that does that. So here are these lines of defense I've been mentioning. So we see the first line of defense involving some sort of cutaneous or mucous membrane, a physical barrier. There are also going to be some specialized chemicals that may help, again, to kind of keep some of these bacteria at bay. So we do have some antibacterial capabilities, some chemical barriers that are contained within those. We'd see maybe like sebum, would be maybe a chemical from the oil glands. But anyway, first line of defense, chemical barriers. Let's see, second line of defense. So we break through that first line of defense, something happens and we get into the second line of defense. Usually we would find that where there's going to be blood supply. So remember, this epithelial covering or epithelial lining is going to be avascular. There's not going to be a blood supply. So if we do breach that first line of defense and get down into the connective tissue area, we do see blood supply at that point. We also see nerve supply. We see lymphatic supply at that point. Okay. So the inflammatory response, so we're going to potentially breach a capillary and get an inflammatory response. This is where we also, if we get some sort of pathogen that makes its way in, we could see some macrophage activity, some big eaters, is again neutrophils. Could be involved in phagocytosis. So yeah, basically keeping things clean at that first line of defense. We don't want these bacteria to go further and then we have to ask for the third line of defense to kick in. So again, notice we've got some innate non-specific stuff going on here. First line of defense, mechanical and chemical barriers. Second line of defense, that inflammatory response and phagocytosis. And then the third line of defense, we're going to skip this first bullet real quick and go to the second one, natural killer cells. Again, the next couple slides we'll talk about those, kind of your introduction, your segue into what natural killer cells are. So we'll look at those in just a few minutes as well. But again, you want to recall those are going to be part of that innate or non-self immune system. So once we breach the connective tissue, once we've maybe made it into the blood supply, so anyway, we get past the first line of defense, we enter into that the tissue level, the connective tissue level, and then we go further and we get maybe into the internal environment or into the bloodstream. Again, at that point, we may have to activate T cells and antibodies coming from B cells. So these are going to be your specific immune responses. And then again, we'll talk about natural killer cells in just a few minutes. So long story short, okay, first line of defense, epithelial lining or covering. It's a mechanical barrier with some enzymes to help with keeping bacteria from getting past that first line. If we get into the second line, we're going to be in the connective tissue area. This is starting it into dangerous territory. This is where the capillaries are. So we want to prevent the bacteria from entering into the capillary network and then traveling to the internal environment somewhere. So the macrophages and the inflammatory response, which we'll also look at shortly, will be triggered. And then lastly, the third line of defense, specific immune aspects and those natural killer cells that are going to be available within the bloodstream. Okay. So anyway, mechanical barriers. We looked at those here, resistance barriers. Now we're looking at inflammatory responses for a few minutes, phagocytosis, and then natural killer cells. Okay, so that inflammatory response, again, we've breached the first line. We're now into the second line of defense. This is where we're going to see the nervous system being very active. We're going to see the capillary networks being active. So that tissue damage is going to be received as a sensory by some of the specific nerve cells that we see. So the inflammatory response is going to kick in. We're going to get what are called chemotactic factors. All that means is we're taxing or we're moving chemicals to an area. So here's that term written out, chemotaxis. That's going to attract white blood cells as well as other enzymes. We're going to see heat, redness, pain, swelling. So chemotaxis, chemotaxins, chemotactic factors. Again, these are all chemicals that are going to go towards a higher concentration or bring a higher concentration of white blood cells to the area. Fever can manifest from an inflammatory response. If this should be localized, heat, redness, pain, and swelling. If it's local, that means we've got some sort of a local injury or a local infection. So if it does spread and manifest, we could get a febrile or fever state. Pyrogens are going to be specific molecules that are going to trigger prostaglandin production. And prostaglandins, remember, are tissue-specific molecules that are going to help focus on just tissues communicating with neighboring tissues, to basically get a communication built between tissues that we need to reset the thermostat. And this could cause shivering mechanisms, sweating. Okay. So some of the mediators for inflammation. I mean, look at how complicated inflammation is. Most of our patients that are going to be coming to us are going to be in some sort of pain situation, and pain is almost always going to be associated with inflammation. And that inflammatory response is what is triggering the feeling or the sensation of pain. Now, how did the inflammation occur? Inflammation could have occurred due to an infection. Inflammation can be due to repetitive use, overuse of skeletal muscle. Inflammation can be due to some sort of trauma, a physical trauma to tissue. So those are the main items. So pain equals inflammation. Inflammation equals infection or injury, basically. So, or we could have some autoimmune issues. So when a patient comes in with pain, we want to determine, is this acute or is this chronic? Is this an acute issue due to an injury? Is it an acute issue due to an infection? All right. If it's no, it's not acute, then we have to look at then, is it chronic due to repetitive use? Maybe they work on the line and their elbow, their wrist, their shoulder, their neck. They have some, between the shoulder blades, they have some sort of inflammation going on due to range of motion. And it's chronic. It hurts all the time. It's numb, it's tingling, whatever it might be. Is it chronic inflammation due to an autoimmune disease? Is it chronic inflammation due to a prolonged infection? So again, why do people come to you when you're working in the medical field? Other than maybe they have to for a checkup or whatever, it's probably because they're experiencing something abnormal, and it's usually going to be pain of some sort. Pain is caused by inflammation. What causes inflammation? Okay. Repetitive use, injuries, traumas to the area, or some sort of an infection. And then now again, like what we're seeing, autoimmune disorders as well. So you can see how complex this inflammatory response is. We get an initial response, so that second line of defense has been breached. We're going to get a histamine response, and then we see a bunch of oddball terms, prostaglandins or prostaglandins we've seen, leukotrienes. This is a type of cytokine. Again, cytokines are going to be kind of like 911 operators. They get the phone call, and the cytokines then hits a couple of buttons and triggers leukotrienes, for instance, to show up on the scene. Tumor necrosis factor as well. As we see all of this cloning, all this hyperactivity going on during inflammation, we may see hypermitotic activity. We want to make sure that we're not getting caught into a loop of being hypermitotic due to the nature of the inflammation. So tumor necrosis factor is there to basically get rid of, eat away any type of excess dead tissue, so it doesn't grow and become a tumor. ILs are interleukins. Again, these are part of that cytokine tree. So the initial response is a lot of action. Again, kinins, cytokines, okay, leukotrienes, cytokines. Okay, we want to induce vessel leakage and endothelial adherence to molecules, so or endothelial adherence molecules. So the endothelium is the lining of the capillary or of the blood vessel. So if that blood vessel has been breached, we're initially going to allow for some leakage to occur to, again, allow for a lot of these chemical mediators to come in and slow that inflammation. When then we're going to start getting adherence molecules. So we need this initially. The vessel gets breached. We're going to promote that breach for just a few seconds to ensure that we're getting all hands on deck, and then we need to seal the hole. So that's what we're going to see, that these adherence molecules start to kick in. At that point, we're going to see more recruitment of cells, the leukotrienes, chemotaxis, and then this one, the platelet activating factor. So we're going to start to see platelet activity. We need, like I say, a platelet. We need to seal up the breach or the hole. So platelets are very good at sticking together and clumping and forming a platelet plug. So again, we're going to induce adherence molecules. So we're going to activate them, and then we're going to get them working. Again, this would be your platelets, chemotaxis, and leukocyte growth and proliferation. So leukocyte or white blood cell activity is going to increase. Remember, some white blood cells fight infection. Other white blood cells work on neutralizing an area. Other white blood cells come in and just clean up the mess. So either way, if we do have a breach, there's going to be a mess to clean up. There's going to be potential for infection. So we need leukocytes to show up. Okay, and then once we've hopefully stopped everything from traveling beyond the site of inflammation, we could start potentially kind of cleaning up the debris, vacuuming a little bit. Again, more leukocytes, especially those lymphocytes. We're going to see antibodies synthesized just in case. The third line of defense was breached. We can have antibodies potentially ready that we're able to recognize maybe what types of pathogens may have infiltrated the area. And then lastly, we need to repair and regenerate. So we do have, these are all different types of specific factors: fibroblast growth factor, platelet derived growth factor, okay, transforming growth factors. So these look GF, GF, GF. These are all growth factors. So we need to repair the tissue. ILs are more interleukins. Again, interleukins are going to help mediate and moderate what's going on regarding any type of pathogen invasion, potential chemotaxis, triggering more. So we get the breach, we start fixing it and repairing it. These guys are kind of like the guards. They're going to stay, kind of hang out and make sure that nothing else maybe came in. And then lastly, again, that tumor necrosis factor. Okay, so we're going to get a clot, fibroblast growth, collagen production. We're also going to dissolve that clot and end up with some scar tissue. So anyhow, a lot of action to trigger inflammation. If we're lacking any of these interleukins, or we're in excess of any of these interleukins, or lacking or in excess of growth factors, chemotaxi, kinins, if there's an imbalance of any of these, that could cause some sort of inflammatory issue, whether it leads to chronic inflammation because we're unable to keep up with removing debris and promoting repair and regeneration. We're kind of stuck in this initial and recruitment phase or response. So that could, so we could just be kind of stuck in a loop right here. Very complex inflammation, and just throwing pain medication at someone who has pain isn't getting to the bottom of why they have the pain. Pain is due to inflammation. These are all the factors, and there are more, but these are the main players of inflammation. So if something's wrong with chronic inflammation and chronic pain, then it's probably one or multiple problems with any of these particular molecules. But the complexity, the ability to test for these is oftentimes dependent on several factors that not every patient is able to get what they need. Not every doctor is able to provide the patient with what they need in regards to testing and coming up with conclusions as to why someone may be having chronic pain. So anyway, you can see that it's complicated. Okay, so phagocytes, phagocytosis. Again, neutrophils are the most numerous of the phagocytes. The phagocytes, they engulf, they produce enzymes, and they digest whatever it is they're consuming. Okay, lysosomes drain the phagosomes. So lysosomes contained Also contained within some of these phagocytes that are going to help with, again, enzymatic production to digest whatever it is these guys are eating. Remember, phago means eat. Innate defense, but also, of course, plays a role in adaptive immunity. Okay, so we see bacteria. We've got a macrophage. The macrophage has lysosomes and a nucleus. Engulf it, release some enzymes, digest it, and then release it. So endocytosis, exocytosis. Bring it in, consume it, spit it out. Again, macrophages, big eaters, dendritic cells. Dendritic means arms or branches. Dendra means branch. Most of these phagocytes are named for where they're located. So a lot of phagocytes live or phagocytes generally live in specific areas. There are some differences structurally and functionally of phagocytes. So they're going to be named oftentimes for their appearance or where they're located. There's a dendritic cell found in multiple areas of the body. All right, we finally made it to natural killer cells. Generally, we would see these guys found in bone marrow. They're produced in the red bone marrow. They constitute about 15% of lymphocytes. So you'll recall that one of your leukocytes or white blood cells was called a lymphocyte. So we had T cell lymphocytes, B cell lymphocytes, NK cell lymphocytes. About 15% or so of all lymphocytes are natural killer cells. They basically kind of go around checking the numbers, and if the numbers are off, or if a cell is lacking a marker, then the natural killer cell will destroy it. So tumor cells, oftentimes cancerous cells, will be lacking a specific marker that natural killer cells look for. So they'll recognize and destroy it. Certainly cells, self cells infected by viruses, because of oftentimes the hypermitotic behavior of these infected cells, they may not possess the right flag or marker. So basically the natural killer cells are kind of swimming around in your blood, looking for receptor sites to bind to. And if they find one, then they will send out their little ID checking device, and if the cell that the natural killer cell attached to doesn't have its ID, then it's going to get destroyed. So these are not B cells or T cells. Remember, lymphocytes, usually we think of them as being B or T cells. 85% are B or T cells, 15% are NK cells. So anyway, they've got a killer activating or a killer inhibiting receptor. So again, if for self cells that are healthy, the natural killer cells are going to find a killer inhibiting receptor. If it's a cell that isn't supposed to be there, or that just isn't supposed to be there, could be self cell. It could be a foreign cell, a pathogen. So that's going to activate the killer mode. So how does it kill? Well, it triggers apoptosis, which is cell death, programmed cell death. Basically, it's going to have a means of injecting an enzyme into the cell that causes it to lyse or be destroyed. So anyhow, natural killer cells floating around, they've got their little activator receptor, their killing activator, killing inhibiting. So a self cell that's healthy and normal should possess both antigens, or both surface molecules. So we see um, the natural killer cell comes by, it's able to recognize and plug in there, and it's got the little MHC class 1 molecule that's going to be able to link to the killer inhibiting receptor coming from the NK cell. So the NK cell says, well, key number 1, key number 2, both locks are available. So plug it in, and then keep moving. Go on to the next cell. We have the killer activating receptor plugging in. We have the killer inhibitor receptor trying to plug in, but there's no MHC class 1 molecule. Okay. So what happens? Well, we need to kill or attack the abnormal cell. So this could be a self cell, this could be a foreign cell. Okay, so a chemical is going to come in called perforin. Perforin means to perforate. So we're going to perforate that. We're going to attach to some sort of integral membrane protein channel and dip that perforin in there, and hopefully we can perforate the cell membrane, get in, add some granzymes, which are granular enzymes that are going to go in and destroy the cell. So other than that, it's fairly straightforward. So natural killer cells are going around and basically just trying to maintain some semblance of order and organization. And abnormal cells or cells that lack the MHC class 1 molecules are going to get destroyed. Now, again, autoimmune response may trigger these natural killer cells to destroy normal cells. So we could have perfectly normal, healthy cells, but there was a mutation somewhere that caused the cell to lack its MHC class 1 molecule. So that NK cell comes in and it destroys a perfectly normal cell. That's a type of autoimmune disorder or autoimmune response, I should say. It is natural for cells to lose that MHC class 1 molecule as they age. So this cell could have been this cell. It's just older. It's past its prime, and basically apoptosis needs to get triggered to prevent this cell from taking up too much space and not doing anything. So that's what NK cells do. Interferons, I mentioned those also in complements earlier. Interferons are released by, they're released to nearby or neighboring cells. It's going to cause it. So inter means between. So it implies these guys are going to come in from neighboring cells and basically produce a bunch of enzymes that are going to block, for instance, a viral infection from spreading. So, so what it does is so a virus comes in, attacks, we'll say a mucus cell in the upper respiratory tract. So interferons are going to secrete some enzymes to try and kind of slow down the progression of the virus, but they're also going to start sending signals to neighboring cells, basically telling them to prepare, okay, get ready for the arrival of a virus potentially. So, so again, they're part of that second line of defense that's going to try and, prevent the spread of the virus. So interferons can interfere with the spreading of a virus just by alerting neighboring cells and telling them to prep. Okay, a complement is a trigger that causes a potential cascading effect, basically a release of all kinds of different enzymes. So anyway, activating the complement cascade. We have the classic pathway that we'll talk about shortly. It basically involves going in and lysing or destroying foreign cells. We could get what's called a membrane attack complex, which we'll look at some of this in a little bit when we get into adaptive immunity. Toll-like receptors, nonspecific, pattern recognition receptors in the membrane. So these don't identify specific antigens. They try to recognize patterns. And if they recognize a pattern and they can trigger cytotoxins and other types of innate immune responses. So that's part one. I think I'm going to stop here and upload that video, and then we'll do adaptive immunity.